Thank you, Sarah. And thank you to all of you for taking the time to join me tonight. I'm going to do my best to make this worthwhile to you so that you get some valuable information to apply in your clinical setting. We did a lot of promotion of this particular webinar on social media, and it started with some posts and some research I shared regarding malpractice suits filed for foot and ankle surgery. And a pretty good study of recently published showed that a lot of the claims derive from failure to institute proper non-operative care before surgery. Not the failure to give the non-operative care, but the failure to provide quality non-operative care. And so that's going to be one theme tonight. And the other theme was this. I posted a picture of this patient of mine who at the time of the picture was 72 years old, and he had come in my office to get his orthotics recovered. He had completed over 50 marathons in his lifetime. And the question I posed is, how could an individual with a flat foot like this complete that many marathons and be functioning at a very high level? So we're going to answer that question actually in just a few minutes. The terminology has kind of changed with this, and I'm going to use the term adult-acquired flatfoot, mindful of the fact that this group published in 2020 a new name called the progressing collapsing foot deformity, and these are noted authors and thought leaders in the orthopedic profession who felt it was time to rename adult-acquired flatfoot simply because of the patient I just showed you. That many people who have extremely flat feet function very well without any symptoms. And they felt it's important to delineate those symptomatic patients and call it a different condition called the progressive collapsing foot deformity. But they also pointed out something very important to me and what this lecture is going to underscore. And that is that the progressive flat foot deformity is not due to simply a rupture of the posterior tibial tendon, but more important, due to a attenuation and rupture of the spring ligament, as well as other ligaments of the ankle and hindfoot. I will refer to their classification system a few times tonight, mindful of the fact that they basically divide the deformity into both a flexible or rigid deformity. I had the privilege of being invited to join this team of orthopedic surgeons, and we produced a paper somewhat challenging the progressive collapsing foot deformity classification system, and more importantly, pointing out we believe that regardless, the deformity begins with laxity of the spring ligament. And with that underlying laxity, which can actually be found in childhood, we will see progressive overload of the posterior tibial tendon and or progressive attenuation of other ligaments, particularly along the medial column of the foot. We really think it begins here in an area that has previously been called the acetabulum pedis, supported by the spring ligament complex and a multiple articulation of the talus, the navicular, and the calcaneus. And that's actually for another lecture in itself. So I've kind of redefined the old definition of the adult acquired flat foot, really focused on the posterior tibial tendon. And today, most authorities agree that it is a symptomatic progressive deformity. I believe, and my colleagues believe, it begins at the spring ligament complex and the talocalcaneo-navicular joint complex, then leading to tendinopathy or progressive loss of ligamentous structures. And so tonight we're going to show you how to evaluate that and, more importantly, how to treat it. So the typical patient who presents with this condition is this is not all patients, of course, but typically it's a female over the age of 50 who does have a history of flat feet all of her life. What causes them to present to you, the clinician, is they develop symptoms. And often they don't complain of arch pain, they complain of ankle pain. And they assume that they sprained their ankle even though there's no history of trauma. many times they've noticed asymmetry with one arch becoming flatter than the other arch. So this is the typical presentation, and it's almost always unilateral. Why it begins unilateral, we don't know. It will sometimes progress to a bilateral deformity, but usually it starts in one foot. So the examination process, I believe, should start with gait analysis. After taking a careful history, I think nothing is more important than simply watching the patient walk because you can learn what their level of impairment is, first of all. This particular fellow has a pretty obviously deformed left foot, but he actually works on his feet all day and he's ambulating really without any limp at all, quite propulsive, but asymmetry and left-sided collapse. This patient, on the other hand, an older patient, left-sided collapse, has a limp. She's unstable. She's a lot more symptomatic. And this is important to get into your mind because it really helps direct the ultimate treatment plan. So we have the patient out in the hallway or we have them standing all ready to watch them walk. So I believe we should do an initial examination in the weight-bearing attitude. And the first thing we look for is asymmetry. In the asymmetry, we look for displacement of skeletal segments, and I'll explain what I mean. So here's a left-sided unilateral adult-acquired flat foot with the so-called too many toes sign, which is really an abducted left forefoot. We also see left heel valgus compared to right, but we also see some other subtle things that I'm going to talk about in a minute, and that's the medial displacement of the ankle joint. The medial malleolus is more medially displaced over the body of the calcaneus in the frontal plane. We will see this on radiographic exam as well. And it's really a shift of the talus and the tibia at the talonavicular joint. And it's slipping medially as well over the posterior facet of the subtalar joint. From an anterior view, a real key feature in looking for asymmetry is the transverse plane position of the fibula and the tibia. This patient shows a very prominent anteriorly displaced lateral malleolus, not seen on the asymptomatic side. The entire fibula and tibia are markedly internally rotated on the foot, and the foot is markedly abducted on the tibia. And so that's an asymmetry and also a plane of deformity that's very important. This is a more subtle presentation. Left foot, we see the anterior displacement of the fibula. We also see the bulging of the navicular and the talus here that we don't see on the asymptomatic side. We don't see quite as dramatic a forefoot abduction in this particular patient, but we're seeing multiple planes of deformity and multiple segments here that are not seen in the asymptomatic foot. The cornerstone of both the progressive collapsing foot deformity, Meyerson's classification, and even the Johnson and Strom classification is determining if the patient has a flexible versus rigid deformity. This is determined in a weight-bearing attitude. The patient is in relaxed stance position, and whether you manually invert the calcaneus or have them supinate the foot, you want to see if the rear foot can be corrected. You want to see if the deformity is reducible. And if it's reducible, it is flexible and it is not rigid. Another very important test to do in the weight-bearing assessment is the single foot heel rise. What does this actually detect? For years, the single foot heel rise, and according to Meyerson and many other respected authorities, was a test to supposedly detect a partial or complete rupture of the posterior tibial tendon. We've now learned that this is not true. Studies of posterior tibial tendon transfer for drop foot deformity show that these patients retain ability to perform a single foot heel rise even though they don't have a functioning posterior tibial tendon. The single foot heel rise test is performed as described with all the weight on one foot, The patient usually supports themselves on a weight-bearing surface like the wall of the clinic or a desktop, and they're asked to raise up on the ball of the foot as high as they can. A healthy subject should be able to lift their heel 5 to 6 inches off the ground, and the rear foot should be noted to supinate or invert as the heel rises. The ability to perform a single foot heel rise has nothing to do with the integrity of the posterior tibial tendon. It has everything to do with the integrity of the midfoot joints. The powerful contracture of the gastroc soleus delivers plantar flexion moment to the ankle, and that plantar flexion moment is delivered through the rigid arch system of the foot to the metatarsal heads, such that the entire foot plantar flexes across the metatarsophalangeal joints and the heel comes off the ground. You must have a stable midfoot in order for the heel to come off the ground. In a patient with an unstable midfoot, as they attempt to lift the heel off the ground, the talus and the tibia plantar flex at the talonavicular joint, and the heel loses the leverage, or the entire foot has lost the rigid beam effect through the arch, and the heel cannot rise off the ground because all of the plantar flexion is in the rear foot, not the entire foot. So as we watch this patient attempt a heel rise, the tibia translates forward, including the talus. A crease occurs at the talonavicular joint, and the heel fails to lift off the ground. We see various extremes. In this particular foot, the heel is coming 2 to 3 inches off the ground, but we see this creasing or flexion of the talonavicular joint. The talonavicular joint is flexing because the spring ligament is lax or probably ruptured, and it disrupts the stability of the medial longitudinal arch and the ability of the entire foot to plantar flex across the toes. If we look at my 52-year-old marathon runner with an extremely flat foot and we ask him to perform a single foot heel rise, he has no trouble whatsoever. His heel comes 6 inches off the ground. There is no creasing across the talonavicular joint because his spring ligament is healthy and intact, as well as all of the ligaments along the medial column of the foot. The single foot heel rise, therefore, detects stability of the medial column and most likely the integrity of the spring ligament. While the patient is still out in a weight-bearing position in the clinic, we will evaluate and detect forefoot supination deformity. This detects rupture of the medial column ligaments just as the single foot heel rise test does. We have the patient supinate the rear foot, or you can do it manually. And when they're in stage 2 adult acquired flat foot, you will see a varus deformity show up where the medial column is elevated off the ground as the rear foot is supinated to a neutral position. This acquired forefoot varus is due to breakdown of the medial column, which we will see on lateral weight-bearing x-ray. Faulting across the navicular cuneiform joint, or in some patients the talonavicular joint, causes an elevation of the first ray off the ground and acquired forefoot supination deformity. Unlike true forefoot varus as described by Root, this deformity is almost always reducible. It's an acquired stretch of the ligaments, making the medial column elevate off the ground, but easily reducible. If it's reducible, it helps with surgical decision making in terms of balancing and plantar flexing the medial column of the foot. If it's non-reducible, fusion procedures across the medial column are usually indicated. Forefoot supination deformity is also detected when the patient is off weight bearing. Here's a patient where we place the subtalar joint in neutral and we evaluate the forefoot to rear foot, and we see what looks like a pretty extreme forefoot varus deformity relative to the rear foot, but it's fully reducible. The forefoot varus actually becomes a forefoot valgus with mild plantar flexion force on the dorsum of the first metatarsal. So this is a dramatic demonstration of acquired forefoot supinatus deformity. Why is that important? Because you must reduce that deformity when you cast them for a functional foot orthosis or a custom AFO device. I'm going to say this again. If you don't reduce that deformity during the casting or scanning procedure, your device is almost doomed to failure. We have learned this over 25 years of dispensing the Richie brace to hundreds of thousands of patients. If we don't correct the forefoot varus deformity when casting, uncorrected here, corrected here, the corrected cast will fit the foot better and control the foot better from the moment it's fitted on the patient's foot. If you don't correct supinatus deformity, the patient will slide right off of the device. The medial malleolus will rub against the limb upright, and the treatment will fail. We'll go over that a little more in a few minutes. While we still have the patient standing, we do the Romberg test for balance. This is an important test because we've learned that patients with adult-acquired flatfoot suffer significant proprioceptive deficits due to pain and weakness, and their balance is severely impaired, which affects their quality of life. And we're going to address that when we do our rehabilitation program. So it's quite eye-opening for the patient to be asked to stand on one foot and balance because they just can't do it. They immediately fall medially because of the weakness of the first ray of the foot. They fall medially. And they ask, why am I doing that? And you explain to them why. And you also tell them that you're going to help them address that and try to correct that. We're going to go to the off-weight bearing assessment of the old adult-acquired flatfoot done in the treatment chair or the exam table. There's a lot to be done at this part, and I'm going to go through this rather quickly because I really want to get to the treatment. Manual muscle testing to determine the integrity of the tibialis posterior is easy to do and does not require an MRI to detect a rupture. The patient is evaluated off-weight bearing with the foot hanging off the end of the exam table. You in your mind draw an imaginary circle along the medial aspect of the head of the first metatarsal. And you're going to place your thumb on the bottom half of that circle. You're going to push your thumb against the head of the first metatarsal and abduct the foot and the ankle to end range. So you're going to push the foot laterally to end range. And at this point, you're going to ask the patient, push your foot against my thumb. And as the patient pushes, you're going to get a determination of how much strength they have in the transverse plane. They're being told to adduct the foot, not invert the foot. And I'll explain why in a few minutes. When you compare to the contralateral foot, it's very easy to pick up a loss of even 1 grade of strength. And when there's a rupture of the posterior tibial tendon, there will be a total loss or inability of the patient to adduct their foot against resistance. Do not begin the test with their foot already inverted or adducted because, as the picture shows, they will recruit the tibialis anterior, and you will not be measuring pure posterior tibial tendon strength. So foot hanging off the end of the exam table, thumb against the bottom half of the first metatarsal head. Patient is asked to push against my thumb. Now for probably the most important test, off weight bearing, is the neutral heel lateral push test. First developed and described by Chandra Pasapulo, who was my co-author in the paper I showed you at the start of this presentation. Pasapulo and co-workers did a cadaver study where they sectioned the spring ligament on a group of 21 cadaver specimens, and they verified that this test will detect a rupture of the spring ligament. The patient's hind foot is stabilized laterally. That's why it's called the neutral heel. You hold the foot in subtalar neutral, but you stabilize the lateral wall of the calcaneus and just the calcaneus, not the cuboid. You then, with your right hand on this particular foot, push in the abduction force, transverse plane abduction, abducting the forefoot against the rear foot, and you measure or get a sense of the range of motion or laxity. Radiographically, when there's a spring ligament rupture, this test will show marked displacement of the forefoot on the rear foot across the talonavicular joint. Chandra shared this very telling video for me of a patient who has a very mild flat foot deformity and is able to easily do a single foot heel rise test in this case, but has significant laxity of her spring ligament, as you'll see. He is now comparing right to left feet with a lateral push. So notice how much play or range of motion there is in the left foot compared to the right. Very little give in the right foot, significant give in the left foot. So this is a patient in early stage of adult acquired flat foot, can easily do a single foot heel rise, but has significant laxity already in the spring ligament complex. Another interesting test to do off weight bearing is the supination lag test. This is a great test to get the patient's attention and acceptance of the fact that they've got a significant problem that's going to require at least a year of treatment. It was first described by Abood in 1998, and he observed that when patients rupture their posterior tibial tendon and they're asked to supinate their feet with the feet hanging in space, that there's a visual difference between what the feet do and the response of the healthy foot to the unhealthy foot. So in this case, when a patient's ruptured their posterior tibial tendon, they can't invert the foot past the midline of the leg. And on the healthy side, they can do it easily. So any of these patients, when you hang their feet off the end of the exam chair and you ask them to bring the soles of the feet together or supinate their foot, they get a dramatic visual representation of their deformity or their disability, which is important because they're going to need to really buy into a treatment program that's going to last at least a year. And finally, we do a measurement of the gastrocsoleus contracture, which is a large contributor to the adult acquired flat foot. It's a very important consideration when in surgery, not so much in the bracing, but definitely in the rehabilitation process to reduce contracture of the gastrocsoleus. Imaging. I'm just going to very briefly tell you, imaging is helpful in confirming adult acquired flat foot, much more important when considering and planning surgical intervention. Two important papers that I've relied on for the past 20 years, very simple, proved with multiple comparisons to healthy controls that these three factors stand out the most in the adult acquired flat foot. On the AP, the talonavicular coverage, on the lateral, Meary's angle, and also the so-called medial cuneiform to fifth met distance. So here's the AP, the talonavicular coverage, which I'm going to talk a little bit further about. The Meary's angle, which most of you are familiar with, very classically distorted in progressive adult acquired flat foot deformity. And then a very simple and interesting one that can be done with a ruler, not a protractor, is just measuring the height of the medial cuneiform, the inferior border, to the inferior border of the cuboid. Research has shown that this height will significantly change unilaterally in the adult acquired flat foot. So we always compare to the healthy foot. Over the past 10 years, we've gained tremendous insight with weight-bearing CT imaging of the adult acquired flat foot, and that's a whole lecture in itself. I'm involved in a research project right now with weight-bearing CT, and this is a patient with progressive collapsing foot deformity. This is a coronal view of the ankle joint area, and we now know that these patients have an inherent deformity of the talus. an inherent valgus alignment of the posterior facet of the talus that may be acquired over years of walking with a valgus heel. But we're seeing some very interesting skeletal contributing factors that are really important to consider in the surgical planning, not so much in what I'm sharing with you tonight with bracing and rehab. So let's get to the treatment, okay? So what are the treatment goals? Obviously, for any patient presenting with this condition, we want to eliminate pain. And the other thing we want to do, and I always tell the patient this, is I want to restore mobility. And when you tell a patient you want to bring back their mobility, their eyes will light up because they have already sensed this impairment impeding their mobility. And particularly for elderly patients, there's nothing more threatening or scary to them than losing mobility and potentially becoming bedridden. And finally, we want to prevent progression of deformity. I want to quickly point out that we will not correct deformity with this treatment program. We can't correct deformity, but if we eliminate pain and restore mobility, we can improve the quality of life to these patients so that many of them can avoid surgery. We let them know what the challenges are, and we let them know that from a surgical standpoint, it's not going to be our first choice. Share with them the scope of most of flatfoot surgeries, adult-acquired flatfoot surgeries, particularly the recovery time and the need to be non-weight bearing in most cases for an extended period of time, which for many of these elderly patients is just incomprehensible. Please review with them the current knowledge of prognosis for non-surgical treatment. And this is an important part of this webinar tonight. You need to be aware of and be able to share with your patient the results of multiple studies that show that treatment of early stage adult-acquired flatfoot and even mid-stage 2 adult-acquired flatfoot can be very successful with foot orthoses, ankle foot orthoses, rehabilitation program, proper footwear, such that the patients will not have to undergo surgery. This is a brief listing of studies done to date showing very favorable outcome with all of those interventions I just mentioned, where the patients in each and every one of these studies were able to avoid surgery. Chow observed 49 patients with a follow-up of almost 2 years. And using a clinical scoring system, almost 70% of the patients had excellent to good results using either a UCBL type foot orthosis for early stage 2 or a articulated custom ankle foot orthosis for later stage 2. 12% of the patients discontinued use of the brace because they improved. Augustine, using the Lace-Up Arizona Gauntlet brace, with a follow-up period of 12 months, found a significant improvement of AOFAS function from 37 to 70.7. Alvarez, in another study with a short articulated AFO, very similar to a Richie brace, found that 80% of the patients were successful in avoiding surgery and were actually brace-free after the follow-up time, which was approximately, well, the follow-up time in this case was less than 1 year. This is a long follow-up, 8.6 years. Johnny Lin defined success as being brace-free and avoiding surgery, which occurred in 70% of patients. Brace-free after a period of approximately 1 year of wearing a brace. A lot of you would say, how could that be? And I'm going to show you how that can be. This is a paper published from the Pittsburgh Podiatric Residency Program. Many of you recognize these authors here. They are noted thought leaders in the podiatric profession. They studied 64 consecutive patients in an articulated custom AFO and found successful non-surgical treatment in 87% of the patients over a 2.5-year observational period. So in summary, we see significant improvement of AOFAS function scores. We see a significant improvement where the patients can discontinue the brace. If we look at surgical improvement, we see AOFAS scores in the 70s, but we also see AOFAS scores in the 70s or 80s with non-surgical treatment. Overall, if we look at all the studies, we believe that 50% of patients in stage 2 flexible, reducible adult-acquired flatfoot can avoid surgery and can discontinue their AFO brace within 1 year and stay healthy for anywhere from 2 to 10 years, depending on the research that you've read. Tell them this opportunity so that they are optimistic and they believe in it and they subscribe to it. Make them understand, though, that this is a 1 year commitment to daily use of wearing their brace every day, in and outside the house, and completing a 12-week rehabilitation exercise program. No matter which stage the patient is in, oftentimes their pain and swelling has to be reduced with interventions just like we use for an ankle sprain, whether it's compression wrap immobilization, taping, or perhaps putting them in a walking boot. We have to calm down the symptoms before we start the rehabilitation program. The functional rehabilitation program was instituted in most of those studies that I showed you previously. It is critical. Putting them in a brace alone is not enough. The protocols that we followed in our practice were developed by Cornelia Kulig here at the University of Southern California, which involves tibialis posterior strengthening, top-down strengthening from the hips down, and also very critical balance training. Kulig et al. Wrote up this protocol in the Journal of Physical Therapy in 2009. The strengthening is done primarily in the transverse plane, not the frontal plane, activating the tibialis posterior, but if it's ruptured, it literally strengthens the flexor digitorum longus to take over as a transverse plane stabilizer of the foot and ankle. Kulig et al. In a separate paper determined a significant and almost alarming weakness of the hip musculature in patients with, at that time, posterior tibial tendon dysfunction. And what's interesting is when patients have adult-acquired flatfoot on one side, which they always do, her study showed that they had bilateral weak hips compared to control patients, that the weakness of the hips was found bilaterally, even though the adult-acquired flatfoot was unilateral. This adds credence to the fact that a proximal weakness may be a contributory factor to the development of adult-acquired flatfoot. So we have to address this proximal weakness with hip strengthening, very similar to what's done after anterior cruciate ligament rupture or other protocols for proximal stability. Many of you are aware of these exercises. Not always are they done for an elderly patient quite like this, but a skilled therapist will modify the exercises to isolate and strengthen the hip abductors and hip external rotators and improve range of motion. Balance and postural control is addressed the same way we do after an ankle sprain, using a variety of challenging devices as well as visual cueing and other techniques to restore proprioception and balance. Finally, we go to orthotic management. There are many studies that have already been published on the biomechanical effect of AFOs treating specifically patients with adult-acquired flatfoot. There's nothing new here, but what's frustrating is many of these studies are overlooked in the surgical community. In short, if we look at all those studies, there's an underlying theme. And the first theme is that articulated AFOs have better effects on restoring normal kinematics to the adult-acquired flatfoot than solid, rigid AFOs, including gauntlets. If we can use an articulated AFO, it is preferable. This particular study showed It compared two articulated AFO designs to a rigid solid AFO and concluded that of the three orthoses they evaluated, the custom articulated orthosis was superior in restoring alignment and improving gait. Another study found that an AFO that included a lateral flange or a lateral extension to control forefoot abduction was superior to a standard articulated AFO. And I'm going to go over that in just a minute. Clinicians often ask, well, should I start with a custom foot orthosis or should I go right to a custom AFO? That's a great question. One easy answer is that many of these patients, when they present to you, are already wearing custom foot orthoses because we know that they've had flat feet all their life, and for various reasons, they received foot orthotics earlier. But if they haven't ever worn a foot orthosis and they have unilateral evidence of progressive collapsing foot deformity, you need to make a decision. Do I start with a foot orthotic or go right to an AFO? And in my opinion, and this is an opinion based on the research I've read and participated in, we know that when stage 2 adult acquired flat foot has set in and we've lost the spring ligament as well as the medial deltoid ligament of the ankle, we've lost coupling of the connection between the tibia and the foot itself. And so as the hallmark of this deformity is massive internal rotation of the tibia along with abduction of the foot. And the only way we can get the foot out of abduction is to externally rotate the tibia. And a foot orthosis is not capable of that, especially when the ligaments have been disrupted. And so when we look at this coupling between the tibia and the foot, these studies have shown that in adult acquired flat foot, particularly stage 3, the coupling mechanism is disrupted and a foot orthosis is not going to correct the deformity. We need to control the tibia. One way to measure coupling, in my opinion, is the single foot heel rise test. If the patient is unable to do a single foot heel rise test, I do not believe a custom foot orthosis is capable of correcting alignment. So an ankle foot orthosis reconnects the tibia to the foot, and it really corrects the malalignment in two critical planes, as I'm about to show you. Internal rotation of the tibia is critical, but also this medial displacement of the talus, which I showed you at the start of this lecture, which is really coupled with abduction of the forefoot. So let's look at this transverse plane. The uncoverage of the head of the talus, the talonavicular uncoverage, is really brought about by spring ligament rupture, and it's really detected clinically by this massive abduction of the forefoot on the rear foot. And so what we see here is really internal rotation of the tibia and talus and external rotation of the navicular and the foot. I showed you this earlier. The fibula and the tibia are markedly internally rotated on this foot, and the foot has responded by externally rotating. And the only way to control this really is to control it at the tibia, which is what a double upright AFO is most capable of doing. So you can see the dramatic correction that we can achieve here. This is a Richie brace with arch suspender, and it's really controlling this foot beautifully in the transverse plane, not by supporting the arch, but by controlling internal rotation of the tibia. So the double upright AFO, like a Richie brace, is preferable because you've got a strap back here that can tighten the limb uprights against the lower leg. And once you tighten these limb uprights, you can control transverse plane rotation of the tibia. If you have a plastic connector across here, like a lot of companies do when they copy the Richie brace, you no longer can adjust the tightness of the uprights against the leg and adjust the control against the tibia. So this control of internal rotation is only possible because of the tightening of the Velcro strap. And we've done studies at the University of Massachusetts showing this is the black line, the marked improvement of tibial rotation with the Richie brace. The next thing we want to do is we want to push the tibia and the talus back over the top of the calcaneus. We want to push against the tibia and we want to, in the frontal plane, abduct it over the calcaneus. Or another way to think of it is we want to push the calcaneus medially and we want to push the tibia and talus laterally. So this deformity where the tibia and talus have adducted is brought on by deltoid ligament rupture and interosseous talocalcaneal ligament rupture. And these skeletal segments shift, and this is really where the pain starts in adult acquired flatfoot. It's sinus tarsi pain and fibular impingement pain brought on by ligament disruption. And so this is really important. We want to get this foot back to here. And we do it by putting key pressure against here. We put a varus wedge under the calcaneus. And we want to push the tibia here. And we want to push the calcaneus medially. So we push this lateral, push this medial, and we put a wedge under the calcaneus here. This is what we do with a Richie brace. And we do this with a perfect mold taken of the patient's foot and ankle in an off-weight bearing position, or a scan of the foot and ankle off-weight bearing. We cannot achieve this correction if we take a scan or cast of the foot weight bearing where this deformity is captured. We can't correct it to the degree of precision as we can if we cast them off weight bearing. So we apply enhancements either to the foot orthotic or to the Richie brace with the following prescription enhancements, which I'm going to go into a little more detail here. So foot orthoses designed for adult acquired flatfoot. I think I got this slide from Larry Huppin at ProLab, who might be actually on this webinar tonight. But typically, a foot orthosis has a very deep heel cup, usually 22 to up to 30 millimeters in depth. That gives a very deep flange to both the medial and lateral aspect of the foot. Oftentimes, there's a sweet spot applied to the collapsing talonavicular joint. Foot orthoses can be very effective in early stage adult acquired flatfoot, particularly when there's not a lot of abduction of the forefoot. This foot obviously shows very little abduction of the forefoot, a fair amount of heel valgus, and we achieved a very nice correction just with a well-molded custom foot orthoses with a medial heel skive and a deep heel cup. Posting is really not that effective in adult acquired flatfoot. A medial heel skive is very effective, but putting a rear foot or forefoot varus post simply causes these patients to slip off the orthosis laterally. We really want to simply invert the rear foot and evert the forefoot with our casting, impression casting process, and let the brace take over the rest. The medial heel skive is very effective in inverting the rear foot, and it can be done very simply by the lab, skiving plaster off the positive cast to create a varus wedge effect to the positive cast correction. But we really want to look at this transverse plane deformity and control forefoot abduction. And forefoot abduction is controlled, first of all, by proper shoe. Secondly, it can be controlled with a lateral flange applied to the foot plate, and sometimes requires a forefoot strap on the foot plate. But don't forget the importance of a well-fitted, stable shoe. A shoe is part of the AFO bracing system. Without a shoe, the brace fails. In this case, you can see this patient abducting off the Richie brace without a shoe. You put them in a well-constructed shoe, they don't abduct anymore. So we evaluate patients in their shoes and we count on the shoe to provide a lot of transverse plane control of the foot. Running shoes can provide this support with reinforcement of the upper, Running shoes with a dual durometer midsole with medial posting with a stable shank are ideal for the Richie brace because they have a deep heel cup and a removable footbed. Applying a medial flange to a foot orthosis, while traditionally commonly used for pediatric flatfoot deformity, actually creates a problem with adult acquired flatfoot. Because in adult acquired flatfoot, there's this tremendous transverse plane instability. And the medial flange simply creates a slide that the patient slides down off of and the foot abducts. So we've learned that a medial flange actually creates a sloped orthotic surface that directs forces laterally on a foot that already wants to abduct. And so we really look at a lateral flange to stop the foot from abducting. Quite the opposite of what many people would think. A lateral flange acts like a wall. It stops forefoot abduction. A medial flange, on the other hand, acts like a wall to stop adduction of the forefoot. So lateral flanges tend to push the foot medially, and medial flanges tend to push the foot laterally. In adult acquired flat foot, we want a lateral flange. We want to put a wall right here along the lateral forefoot and push this foot medially. Okay? Another way to think of it is we want to block lateral forefoot abduction. So we want to block this foot from slipping laterally with a shoe or with a flange. Now, this is a right foot Richie brace, and the flange extends just proximal to the head of the fifth metatarsal. It doesn't end at the cuboid. It's an extended lateral flange just to the head of the fifth metatarsal. So here's a patient with a unilateral abduction, stage 2 adult acquired flat foot. And here she is with a Richie brace with an extended lateral flange, what ends just proximal to the fifth met. And you can see a very dramatic change of alignment. Just in static stance, it's even more dramatic when you watch them walk. Some people say, well, isn't that uncomfortable? Doesn't that dig into their foot? And I tell them, not at all. If you've casted their foot properly in a non-weight bearing position and removed all forefoot supination deformity, they will hardly even feel this flange against their foot, particularly if you put a padded top cover on the flange and the extension. Some patients, this is a severe stage 4 with severe ankle valgus deformity and abduction, where in this case we do the lateral flange, but we also put a Velcro strap around the forefoot before they slip their foot into the shoe. And this is actually very powerful as well. It's not necessary for most feet except for stage 4. So in later stage 3 deformity, where the deformity is more fixed, we developed an enhancement called the arch suspender. And this is a very powerful corrective device for the talonavicular joint. So in a severe, prominent collapsing talonavicular joint, we put this lifting strap on, and there's a padded Corex pad affixed on the bottom. And the patient's allowed to self-adjust and correct the collapse of the arch as well as the talonavicular joint subluxation. This is called the medial arch suspender. It's recommended for late stage 2 and stage 3 adult acquired flat foot. Finally, severe rigid non-reducible deformity with arthritis of the ankle and subtalar joint. Definitely a gauntlet is indicated here. But a gauntlet is not indicated for all of the other stages I've shown you this evening. I believe gauntlets are overprescribed, probably because of their handsome reimbursement, but they play a role here when you have absolute deformity in the ankle joint due to deep deltoid ligament rupture. And a gauntlet type device literally locks the ankle joint and the subtalar joint to control pain from arthritis. It takes up a lot of room in the shoe. It's very rigid, but it sometimes has a place when deformity is severe. Happily, most of these patients who present are not in stage 2 deformity, and they can benefit from an articulated AFO device. Okay, so how do we institute this program? We prescribe hopefully a Richie brace, and we evaluate the patient 2 weeks after brace dispensal. And then we evaluate the patient every 3 to 4 weeks until they've completed their supervised physical therapy program. We want to keep in touch with these patients. We want to make sure they're going to therapy. We want to make sure they're getting relief of pain from their brace and that they're being compliant. I will tell you that at least 50% of patients, if the brace has been fitted properly, are already experiencing pain relief by week 2. They experience pain relief sometimes as soon as the first day after brace dispensal. But you've got to keep in touch with them because it's a long process. After they've completed rehabilitation, which is usually 12 weeks, we evaluate them every 2 to 3 months for a period of 9 months. Again, keeping touch, making sure they're being compliant, making sure there's no problems with the brace or any change in their symptomatology. We begin thinking of moving them out of the Ritchie brace at about month 9. And we've told them this from the very beginning. Our goal is to get you out of this brace between 9 and 12 months into a custom foot orthotic. And we know we can do this about 50% of the time in stage 2 and stage 1 deformity. If the patient has been relatively pain-free for 6 months, I think it's time to start testing the waters and have them go without the brace, but with a custom foot orthotic in its place for 2 to 4 hour increments. Depending on whether they develop any symptoms, you begin increasing the time out of the brace. During this transition phase, we keep in touch with the patient. We evaluate them every 2 weeks because it's tricky. Some of them relapse right away. Others, at least 50% of them, they don't relapse, but they get excited and they tend to overdo it. And sometimes they walk around barefoot. They're out of their brace, so they don't think they have to wear shoes, but they have to wear shoes and they got to wear their orthoses really for the rest of their life. So how long, like I said, do they wear the brace before continue moving out? I'd say 6 to 9 months. What about the patient who comes back after week 2 and comes back after week 4 and they say, "Doctor, I am not any better. I'm dying of pain. I haven't felt any relief of pain from this brace." I will consider immobilizing them for a short period of time just to calm down their symptoms and then go back to the AFO brace. I do not give up at this point and recommend surgery. I'm amazed how many of these patients with a short-term, significant immobilization, sometimes even in a cast, it will calm down the synovitis and allow that brace to do its job. So just a couple quick cases here. This is a severe adult acquired flatfoot after a lumbar laminectomy that resulted in a paralysis of the tibial nerve that left the patient with a drop foot and a adult acquired flatfoot. And that's our arch suspender. So giving that powerful transverse plane control as well as frontal plane control. Now you can see she's wearing running shoes. And this is a great story because she walks 2 miles a day for exercise in her running shoes and her Ritchie brace despite this severe deformity. This is a fellow who works in work boots during the day. He works at Disneyland on the railroad there. He drives the train. You can wear the Ritchie brace inside of a boot. You just have to loosen the boot upper. You don't really need the boot anymore because the brace takes over. But for the workplace and the steel toe, he has to wear a boot with his uniform. You can see the correction of alignment of the tibia over the calcaneus. You can see how straight the tibia now is over the calcaneus. Here's that patient with stage 4 ankle valgus, and he's the patient that got the forefoot strap. Now, this is a wild one. This is a patient who wore his Ritchie brace in a sports sandal. And you might say, you can't wear a Richie brace or any AFO in a sandal. Well, it's not my first choice, but I practice in a beach community where people do wear sandals in the summer. And the critical feature of the footwear is the straps or the forefoot control, a stable upper. And sports sandals have straps across the forefoot, and they also have a heel strap to hold the heel in. And the brace doesn't come out of the shoe because it's strapped on the leg. For those of us who put foot orthoses in sandals, and you can see that he's wearing a foot orthosis in the right sandal, there's a tendency for the orthosis to slip out the back of the sandal. But the brace doesn't slip because it's attached to the leg. And you can watch this guy walk. It's rather remarkable. No sock. The brace is totally comfortable. And he wears it all day with his sandal for control of his unilateral one-sided adult-acquired flat foot. Here is a more typical. This was the woman I showed you at the beginning of the webinar who's got a disability. She's limping. And she was recommended a very ambitious surgery by one of our local surgeons, which I don't think she ever would have been able to tolerate the non-weight bearing recovery. And so we put her in just a standard Richie brace, no arch suspender, and she's wearing SAS shoes. And you can see the remarkable improvement of alignment and really the lack of any limp. And this is slow motion. So, but you can see it's a very stable transition from right to left feet, no limp. And for her, it completely solved her pain and changed her life for the rest of her life. Just a couple final things. With scanning, we're getting so many doctors who take a scan of a patient's adult acquired flat foot like this hanging in space. And we can't do that. The same principles that we always prescribe for casting are applied to scanning. If you scan this foot without reducing the acquired forefoot supinatus deformity, that brace will fail. You must position the foot in subtalar neutral and reduce supination deformity. The practitioner must position the foot while the assistant takes the scan of the foot. Otherwise, we're going to fail. You can't scan it hanging in space. This is the proper way to scan. It takes two people. The doctor positions the foot and the assistant takes the scan, either with an iPad or now today can be done with an iPhone with a front-facing camera. Don't scan the foot hanging in space. This will be an entirely different shape and different function brace than this one. This brace will fail. This brace will fit. You must push down gently on top of the first metatarsal to remove forefoot supination deformity when treating the adult acquired flat foot. This is really a problem, not just in our profession, but in all specialties treating foot and ankle conditions, that somehow digital casting eliminates the need for proper positioning. I saw this picture on LinkedIn of a student at the new podiatry school, University of Texas, Rio Grande, taking a class in how to scan the foot for a foot orthotic. And it just drove me crazy. And I reposted it on my LinkedIn page because how can we be teaching student doctors that this is proper to just let the patient's foot hang in space and all you do is point your camera and shoot? Why do we need a doctor? Why don't we just let the patient have their spouse do this at home and get rid of the doctor out of the equation? Because this doctor here is not adding any value or expertise to the process of proper positioning and getting a good patient outcome. I've done several webinars on proper positioning and scanning. And I also have a couple teaching videos on proper scanning on the Richie Brace website. You simply go to our website, richiebrace.com, and you click on casting, and you get to see all these nice videos that we've made that go into quite a bit of detail on how to do the proper scanning process. A single person can now do the scan with a front-facing camera with an iPad or iPhone, but it's not ideal. I mean, I use two hands to cast because I got to push down on the first ray. But in dire circumstances, this can be done with a single practitioner. You just got to use that index finger and reach over the top of the foot and push down on the first ray. I want to finish with this picture. I took this picture of this patient. Her first name is Catherine in the late 1990s when we first introduced the Richie brace. And she came in with bad feet, but the right foot was way worse, and only the right foot was symptomatic. So I made her a foot orthotic on the left and a Richie brace on the right, and I put her in motion control running shoes, and her pain went away, and she started walking for exercise every day and enjoyed the benefits of that for about a year. And I moved her out of the Richie brace. This is her. I showed you her foot several times, a terrible foot, terrible transverse plane deformity. She came in regularly over the years to have her foot orthoses recovered because she never wore the Richie brace after the first year. And I took this picture of her feet 20 years later, and her feet are still very deformed, the right worse than left. But for the past 20 years, she walks 2 miles a day and she's brace free, and she never had surgery, and she's happy with the quality of her life. And so this is really our goal. It's not to correct deformity. It's definitely to prevent progression of deformity, but more importantly, it's to restore mobility. And that's really the slogan that's on every Richie brace on the label. It says Richie brace, but right under it, it says restore mobility. Finally, I just wanted to put something else positive on here. And we all know that our fees keep getting reduced and never keep up with inflation. But Medicare does increase DME payment every year. Since 2005, the reimbursement for the Richie brace has gone up almost $300 over, over the past 20 years, and the price of the Richie brace has only gone up $5. So the profit of the Richie brace is over $600, and it's actually increased by almost $300 over the past 20 years. So really a positive thing in every way, and I wanted to emphasize that as we end. So I went a little bit over. I appreciate your patience and taking the time. I'm happy to stay on and answer any questions. I do want to point out that this webinar was made possible by my distributors. The Richie brace is available by a network of elite podiatric labs and orthopedic labs who provide the Richie brace as well as foot orthoses. These labs are listed on the Richie brace website, and these labs are the only way you order a Richie brace. You order the brace, you pay for the brace through the distributor, and you get all of your problems solved by the distributor, including refurbishment and replacement parts. So these labs are listed here on the Richie brace website, and I thank them again for their support. And so with that, Sarah, if you could tell us if we got any questions, if people have written any down.
Absolutely. We've got a couple coming through. So we'll start with these two. And I definitely encourage everybody who's still online. First of all, thank you so much for sticking with us the whole time. So we definitely appreciate that. Let's get into a dynamic Q&A session here. Okay, first question. Are there benefits to a closed posterior connection of the uprights versus leaving it open to tighten the uprights to stabilize the lower leg/tibia?
Only for control of the sagittal plane for foot drop. Um, I I suppose, and I have a lot of orthotist friends, and I consult and work with orthotists who love to connect the two uprights, and they make an argument about the pillar effect of them being connected, theoretically providing sagittal plane and sagittal plane stability and some frontal plane. But I just never saw that. I had so many patients come in my practice with those connector uprights made by other labs, and I would put them in a Richie brace with the strap, and the difference was night and day in almost every case, and the patient immediately validated that. So we do a posterior connector. If you want one, we make that for you, and we actually recommend it for foot drop, but not for this, not for adult acquired flat foot.
All right, fantastic. Okay, next question. While casting, does engaging the windlass mechanism with dorsiflexion of the hallux in addition to plantar flexion of the first ray produce any difference in success of the device?
Great question. That was really a technique proposed by the late Paul Scheer, a very good friend and mentor of mine. Um, he argued that it would accomplish the same thing. I would argue when you dorsiflex the hallux, it causes the plantar aponeurosis to bowstring. By bowstringing, it tends to pull the plaster off the foot, or it pulls the skin away from the foot, and we don't get quite as good of a tight contour of that critical medial edge of the orthosis against the medial column of the foot. So I don't like to dorsiflex the hallux. I'd rather just gently push down on the head of the first metatarsal from the top.
Okay. What diagnosis for Medicare reimbursement?
Great question. So we have a very nice page on our education page and also on our billing and coding page where we give you suggested codes, which actually don't use that as a gospel because these ICD-10 codes have been upgraded every year. But let me just answer your question in a valuable way. There is no code for postertibial tendon dysfunction. There is no code for progressive collapsing foot deformity. There is a code for flat foot slash acquired, which is what this is. And so I recommend that you use two codes in every case. And so we put flat foot acquired and rupture of tendon, foot, and ankle. There is no code for the posteriotibial tendon, but there is a general code for ruptured tendon of foot and ankle. All of this is well spelled out on our coding page in our website. Medicare is really looking for two codes. They're looking for a code that describes the deformity, and they're looking for a code that describes a pathology, like a ruptured tendon. So the deformity is talipes valgus, flat foot acquired. The pathology is really a ruptured tendon, foot, and ankle. You could put synovitis. You could put arthritis if it's visible on x-ray. I would use at least two codes. That's all I can tell you. And don't use forefoot codes. Don't put hallux valgus in there. You definitely could put contracture of the gastroc, equinus deformity, and all of that is spelled out on our website.
Okay, next. Do you try bracing and casting before injections for pain relief?
Yes, I I rarely would have to inject these. It's obviously they have a lot of sinus tarsi pain and subfibular pain, which is really tempting to just get a needle in there with some steroid because it gives them instant relief. But that wears off, and you still have to immobilize them. So I normally wouldn't do that, but nothing wrong with doing that if your immobilization isn't working for sure.
Do you prefer plaster casting or digital casting?
Prefer digital casting. Tell you why. And this is in the webinar I did on it. Um, you know, with today, with the ability to take a scan, and every one of our lab distributors has an app which they provide you. And when you take that scan and use their app, you enter the order right on the spot on the app, and you transmit that scan to the lab. And literally within minutes, that order has been entered into our distributor lab's data bank, and the workflow process begins. The order begins. The work starts on the brace. Compare that to 5, 10 years ago when you had to let the plaster dry overnight and then pack it and ship it to the lab, which would take 5 days. And then the lab would unpack it, and the lab would have to do the order entry process. And it might take a day for them to even get that started. You've literally wasted a week with the old-fashioned way. And with digital scanning, it starts literally within minutes. There's many other advantages to scanning, not to mention the environment. I mean, we're not wasting plaster, we're not storing plaster. Uh, we're using a high-tech technology that can be shared with the patient where you can show them the scan of their foot and ankle. It really sells them on the technology of what you're doing and your own knowledge and skill level with the scanning process. So nothing but positive things about it. The negative side of it is it makes doctors tempted to take a shortcut and not adhere to proper positioning. That's my only criticism.
So I'm going to skip down a couple because it's related to the digital casting. For digital casting, is it better to use an iPad or an iPhone?
It's better to use an iPad with the new structure sensor too, because it's more accurate and it can be taken with a back-facing camera, not with a front-facing camera. The downside is the structure sensor scanner is more expensive. It's at a cost of anywhere from $600 to $700. But if you have a practice that does a lot of foot orthotics and a lot of AFOs, it's a one-time investment that does take a better scan. It's more forgiving and easier to use. Having said that, um, the software that our labs have developed with the app and taking a scan with a front-facing camera with an iPhone is certainly convenient and almost of no cost to you. There's a little bit more of a learning curve with it. So um, I'm not downplaying it at all. It's just given the choice and you want to spend the money, the iPad is better.
Awesome. Let's see. Without proper codes, are there good guesstimates in the literature as to how common this condition is?
Yeah, that's a great question. In some of the articles that I've written on this, and they are posted on the Richie Brace website, there were a couple good studies done in the UK, and they believe the prevalence, believe it or not, is 5% in the adult population, which is significant. So it's a very common disorder and it's not always treated. That's the problem. I mean, a lot of these patients never go to the doctor because they've had flat feet all their life and they've basically been told since childhood there's nothing to be done about it. And they actually don't start getting pain till they're 50 or 60, but they have this in their head. There's nothing more to do, so they don't go to the doctor. So it's a very well documented disorder, which I don't know of any insurance companies now that deny treatment of the adult acquired flatfoot. They definitely deny treatment of pediatric flatfoot, but adult acquired flatfoot, you've got to document the other pathologies, the tendon rupture, the acquired arthritis, the synovitis, the gastroc soleus contracture, like I mentioned earlier.
So we have an individual who the clinic is self-pay, but even so, can the DME be paid through insurance?
Oh, yeah, I want to make sure everybody understands this is not a Medicare only device. Um, it is reimbursed by private payers and workers' comp. The level of reimbursement varies significantly from plan to plan. I'll be the first to admit Medicare probably pays the best and the easiest and the most prompt fashion compared to private payers. I would definitely pre-authorize payment from private payers, third-party payers. Um, Many of them follow the Medicare criteria and the Medicare fee schedule. A lot of clinicians, and myself included, provided this brace to patients for self-pay. I never had a patient ever tell me that they thought it wasn't worth $800 or $1,000. The relief of pain and the restoration of mobility, literally changing someone's life, is worth way more than $800, believe me. Um, don't be bashful of offering it to a patient for self-pay at least that price point. And that's basically the low level of what Medicare pays, by the way. In some regions, Medicare pays $1,200 for it. But in Australia, the Richie brace is extremely popular. It's all self-pay, and most practitioners in Australia charge $1,000 a brace, and patients have no problem paying it, and they do not want their money back once they get it because the change of their life is so profound.
All right, I love that. Um, we love these sorts of questions, Dr. Ritchie. For same and similar, can you dispense a Ritchie brace after an L1902 as given for immediate pain control?
Um, yes and no. And I was going to go into that tonight because I showed a picture of a walking boot. And if you dispense a walking boot and bill Medicare for the walking boot, and then a month later bill Medicare for that same patient for a Ritchie brace, and you use the same diagnosis, the Ritchie brace is going to get denied because it's same or similar. And that's a travesty. And so you've got a couple of choices. And I gave a whole webinar on this, and it's on our website at the recording of it. And I urge you to watch it because I discussed this exact scenario. And what I basically suggested is have the patient pay cash for the walking boot. I mean, how much are you going to charge him for the walking boot? How much does it cost you? It pales in comparison to the cost of the Ritchie brace. But if you dispense and bill Medicare the walking boot, you're pretty well disqualifying that patient from a Ritchie brace unless you justify with a different diagnosis and that the medical condition has changed from the day you dispense the walking boot to the day you actually dispense the Ritchie brace. Now, some people would argue, yeah, the condition has changed. They don't have acute synovitis. They don't have near the edema, the pain level, whatever you're going to justify. Maybe you can do it, but I just think you need to be careful. If you dispense any type of prefabricated ankle brace before a Ritchie brace for this condition, the Ritchie brace is going to get denied unless you come up with different diagnosis and your medical record clearly describes that the condition has now changed, justifying why you now need a different brace with a different L code than the original prefabricated brace. You could say that the patient now requires a custom brace because the original brace was not addressing the patient's needs. Their symptoms were not getting better. The condition had not improved. That's actually one of the requirements for a custom brace is that a prefabricated brace had failed to address the original treated condition. It failed to work, really, for a matter of speaking. So it can be done very legitimately and legally. It's all with the way you document in your medical record. And I've got a lot of information on my website in writing and also a webinar on that that I think would be very helpful to you on that.
Awesome. Cost of a scanner.
Like I said, a structure sensor scanner is going to run between $700. The app for your iPhone is free from most of our lab partners.
Yeah.
So any of these lab partners are happy to give you an app to convert your phone into a scanner.
All right. What are the three biggest, sorry, let me rephrase. What are the biggest three issues you see with clinicians and how they can correct these issues during, I don't know if this is getting cut off. Oh, okay. Sorry. I think my Dayquil is wearing off.
Okay.
Let's try third time's a charm. What's the biggest three issues you see with clinicians and how they can correct these issues ordering the brace?
Well, the biggest issue is proper positioning of the foot. And I didn't go into that in this lecture. Again, I've done a whole webinar on that and it's on our website. But whenever I have a clinician call me and say that they failed with a brace, the brace is rubbing the medial malleolus or patient can't tolerate it, I always go back and I go, well, tell me how you casted them or scanned them. Can you tell me what position you put them in? Da, da, da. And every time they either said they didn't position it or they don't know what forefoot supinatus is. They didn't do that almost every time. Um, and sometimes it's failure to fill out the prescription form properly and apply the enhancements that we recommend, like a 6 millimeter medial heel skive, a lateral flange. That can sometimes lead to failure. So I think say three things: the failure to properly position, failure to properly fill out the prescription form, and I'd say the third thing is failure to properly educate the patient. Educate the patient about changing their footwear to a proper shoe that provides the necessary support and fits the brace. Failure to refer them for rehabilitation and therapy, and failure to monitor the patients and make sure they're being compliant. They have to wear the brace in the house. You can't walk around barefoot. You have to wear this brace from the moment you get out of bed in the morning till you go to bed at night. So, those are probably, I would say, the top three factors for success. Hopefully, I answered that question right.
I know you answered that question right. You're Dr. Richie after all.
Yeah, right.
Well, it looks like that concludes our Q&A session. And, we were worried about going way over time. I think with the amount of content and the amount of questions, I think we, made a world record here for efficiency. So, thank you so much, Dr. Richie, for sharing all of this information with. We had a little over 100 people live this evening, which is incredible. Again, we had 243 register. I know it's really difficult for everybody to join live. So that's why, again, just a reminder, we do have this recording and it will be live on Dr. Richie's, the richiebrace.com website in the next 48 hours under the education tab of webinars. But if you can't remember all of that, I will be shooting you an email. So I know how much you love seeing those pop up in your inbox.
Exactly.
Any final thoughts, Dr. Richie, before we say goodnight?
No, I thought all those questions were great. It shows two things. It showed that you stayed on the webinar and got something out of it, and it also showed that you're really thinking about this critically, which is great because in the end, it's that critical thinking that you take back to the clinic and apply to the patient, and you're going to get a better outcome, which is really good. So I really appreciate that. Thank you.
Awesome. All right. Happy Valentine's Day early to everyone and go buy some chocolates.
Okay. Thank you,
Good
Sarah.
night.
Always great to work
Well,
with you.
thank you always.
Okay.
Good
Thank
night.
you. Bye bye.